So today I'm going to begin these talks with an overview of a simple approach, hopefully, to what we call simple acid-base disorders, as opposed to acid-base disorders that are in combination. We call those complex acid-base disorders. So when there is one acid-base disorder, we call that simple. But before getting into the clinical approach to acid-base disorders, it's important to understand some of the underlying chemistry which would occur both in vitro, and there's specific chemistry that occurs in a body, in a mammalian body. So the first thing to realize is that historically, the approach to acid-base balance has focused on what we call the bicarbonate buffer system. Now, we didn't have to do that because we have many buffers in the body, but because it's the most prevalent buffer, and also because the acid species is volatile as opposed to phosphate, other buffers in the body. One of the buffers is actually can be a gas in equilibrium with blood. This was the approach taken because it also represents organ function. The volatile acid is controlled by the lung, and we'll get into that. So the first thing to understand is something called the bicarbonate buffer equilibrium, and that's shown at the top here, where carbon dioxide plus water forms something called carbonic acid, which then can break up into a proton and bicarbonate, and the bicarbonate can further break up into a proton and what's called carbonate. We don't tend to think of carbonate, but all these things are what we call are in equilibrium with each other, which means when we have an arrow, the forward and the backward reactions are equal and they reach what we call a steady state. A steady state just means the numbers aren't changing. So that's the first thing to think about, that we have all these carbonated species. We have carbon dioxide, carbonic acid, bicarbonate, and carbonate. In fact, we have 4 of them. Now, when we send off a panel to measure your electrolytes, we get something back that people tend to call the CO2, but that if you cannot do that, I know you did that in your residency, and I know most faculty in nephrology and in medicine call this the CO2. In fact, it should be called the TCO2. It's the T represents total, and that's what you're measuring. This is not from a blood gas. This is the number that comes back with the sodium, potassium, chloride, BUN, and creatinine. You get something back that people call the CO2, but from now on, you should call that the total CO2. And it represents all the carbonated species that I just alluded to: bicarbonate, carbonate, carbonic acid, and carbon dioxide, not that's in the air, but it actually dissolves in the blood. So we call that the dissolved carbon dioxide concentration. And when you're getting this number back, it's the sum of all of them. Now, people also tend to call it bicarbonate sometimes, and that's incorrect. Do not call it bicarbonate anymore. And these slides I'll make available, so you can take notes if you want, but I'll send them to you, and if you have any, or they'll be available in box or whatever, however Ruth wants to transmit them to you. But if you have any questions, please just email or text me. But the second error that people make is calling this bicarbonate. It's not bicarbonate. Bicarbonate, as I'll show in a minute, can only be calculated from the blood gases. It cannot be measured. We can measure the total CO2. Now, granted, this is mostly bicarbonate. I mean, these aren't equal in concentration. If this comes back at, let's say, 26 millimolar, most of it is bicarbonate. 24, 24 and a half, 25 millimolar is bicarbonate. And that's why the error isn't a terrible one. But if you want to be correct chemically, don't call it bicarbonate. The carbonate is in micromolar, so you don't have to think of that. The carbonic acid is micromolar too. We're talking about 1,000th of the concentration of bicarbonate. The dissolved CO2 is in the millimolar range, but it's pretty trivial. The way you can calculate it is you take 0.03 and you multiply that by the PCO2. So if your PCO2 is 40, 0.03 times 40 is 1.2 millimoles per liter. And The 0.03 is the solubility coefficient for carbon dioxide. Every gas has a solubility coefficient, oxygen, nitrogen. If you shake them with a liquid, you can calculate based on the solubility coefficient how much dissolves in that liquid. And for carbon dioxide at 37 degrees, it's roughly 0.03. It's just as far as the absolute value, forget the units. And so to address how much of this is coming from carbon dioxide, you take 0.03 times the PCO2. Now you can see if someone has a respiratory acidosis and the PCO2 goes to 80, then this will be, 0.03 times 80, which is 2.4. It becomes a bigger component of the total CO2, and it has nothing to do with the change in bicarbonate. So you just have to think that the total CO2 is the bicarbonate plus this, with it being mostly bicarbonate. Now, another important thing to realize is these numbers have a relationship with each other, and sort of the historic standard formula is the Henderson-Hasselbach equation. But in the 1960s, in an article in the New England Journal, Bleich and Kazirer, who were nephrologists at Harvard, came up with this equation because clinicians don't like logs and the formula is hard. It has a lot of parameters in it. So this is sort of a short form. And what it says is the hydrogen ion concentration, not the pH, the hydrogen ion concentration is this constant 24 times the PCO2 over the bicarbonate. And if you look at the numbers we typically think about, this is not 7.4, that's the negative log of the hydrogen ion concentration. The hydrogen ion concentration is 40, forget the units. The units are very different. This is 40 nanomolar, 10 to the minus 9 molar, equals 24 or 25. People interchange the two. I should probably correct the slide. It should be the same as this. This should be 24 times 40, the number we typically think of for the PCO2, over 25, the bicarbonate. Now, the reason for knowing this is, number one, if you know two of these numbers, the third must be true. That's number one. And in fact, when you send a blood gas down, they measure the pH, and then for this equation, you need to convert it to hydrogen ion concentration. But the point is this is measured, and the PCO2 is measured with a PCO2 electrode. The blood gas machine does not have a way of measuring the bicarbonate, but the machine knows the Henderson-Hasselbach equation, or the short form of this, if you will, and gives you back a calculated bicarbonate. Now, some people think, well, it's calculated, so it's not true. That is incorrect. If the PCO2 was measured correctly and the pH was measured correctly, then your bicarbonate must be that number. So that brings up sort of the practical and philosophical question, which number do I look at? Do I look at the total CO2 and say, well, it's mostly bicarbonate and use that when I'm assessing an acid-base disorder? Or do I use the calculated bicarbonate from the blood gas machine? And we'll talk about that in later talks, because there are situations actually where these are different, and you have to look at both and come up with the reason why, and then maybe you have two different acid-base disorders. But the bottom line is that these numbers that we think of clinically have a mathematical interrelationship. Realize again, we only measure two of the three. And the final point, as shown here, is that these numbers represent not just a number, but organ function, because it's the kidneys that determine your steady state bicarbonate concentration, or for that matter, the total CO2, and it's the lungs that determine the PCO2. So under normality, they create these numbers, and then under abnormality, these numbers can give you a clue in the reverse direction that you have abnormal organ function. Does anyone have any questions so far about what I said? Things that weren't clear? Okay. So one of the issues is the blood gas machine measures the pH, but that equation has hydrogen ion concentration in it. So nowadays with the iPhone, it doesn't make a difference, but if you want to just use your head, this is a simple way of converting pH to hydrogen ion concentration. If you remember that 7 is 100 nanomolar, if you just keep taking 80% of the previous number, then you can predict what these are. So 7.1 is 80, 7.2 is 64, 7.3 is 51, 7.4, and you can interpolate in between too if you want to figure out, let's say, what 7.35 is. But this is just a quick and dirty way of converting the pH to hydrogen ion concentration. And the reason for doing that is this equation also allows you to check the lab. Now, nowadays, there isn't an error, but if you get back a PCO2 of 40, and a pH of 7.4, and this number comes back at 28 or 30, there's something wrong with the lab report, because this number must be 25. Or if this comes back at 25 and the total CO2 is not like 26, you have to think that maybe one of these was measured wrong, or there's just some discrepancy. But when you get the blood gases back, even before you start thinking about clinically what might be going on, before you waste any neurons saying, you know, what does my patient have, a metabolic acidosis or whatever it is, you want to make sure these numbers fit the Henderson equation. It's not called the Henderson-Hasselbach equation. It's the short form of the non-log form of the Henderson-Hasselbach equation, and combining the solubility of carbon dioxide and the pK of the reaction. That's where this 25 comes from. So it allows you, because of this mathematical interrelationship, it allows you to test the lab. We don't have that with other lab values. You know, the CPK doesn't equal 25 times your bilirubin over whatever. You know, you can't test labs other than repeating them, but with acid-base values, you can test the clinical lab. So it's useful. Plus, it just teaches you conceptually that there is this interrelationship. Now, the other issue is that people don't realize is that there are male-female differences. The numbers we tend to think about historically are male numbers. The PCO2 in men tends to be higher than women. Now, it's not a lot, but if you take 100 women and 100 men and you average the PCO2, you're going to tend to get a slightly lower number in women. And the bicarbonate is also a little bit lower. Now, if you're trying to make very, very subtle acid-base diagnoses, obviously, like other things in medicine, the best thing is to have the patient's previous values. But typically we use population norms. So if, let's say, the PCO2 in a patient is 46, and someone asks you, well, how much above normal is that? And you don't have the patient's previous blood, the typical answer will be 6. It's 6 higher than normal. But that's only true in men. In women, it might be 8 or 9 higher, which means there's more of a severe disorder. So it's important to know this discrepancy. The other thing is that in women, at mid-cycle, the PCO2 drops. In fact, years ago, people used to measure the PCO2 to tell when a woman ovulated. Now, we don't do that anymore, but at the time of ovulation, with progesterone going up, it tends to drive the medulla in the brain, and the ventilation rate goes up, and you excrete more carbon dioxide, and your PCO2 drops. So there's that dynamic change at mid-cycle, but there's also this sort of average steady state difference between men and women that really has not been explained as far as I can see in the literature. And again, it's just an average. Obviously, you can have men with a PCO2 of 37 or 38 and women with a PCO2 of 42. That's why it's important in acid-base numbers, like everything else in medicine, not to compare to population means, but to know what your particular patient was before. It's the same concept as the anion gap. When you ask someone, how much has my patient's anion gap gone up? Well, you can look at the population mean, but it's much better to know what the anion gap normally was in your patient. So that would be your delta anion gap, rather than assuming what it was from a population. The other important thing to realize is that there are arterial venous differences. And typically the total CO2 came from venous blood, and the arterial numbers came from arterial blood. So when you're looking at the discrepancy between the calculated bicarbonate and the measured total CO2, sometimes there's a bigger difference than just one or 1.5 because of the difference in the dissolved carbon dioxide concentration of 1.2, increasing the total CO2 by a little bit more than just the bicarbonate. There's the difference also in the artery versus the vein. And it's important just to remember those differences, because sometimes you want to get venous blood gases. It's just easier. And in most situations, you can diagnose the acid-base disorders equally as well. If you're not interested in the PO2, no reason not to start with venous blood gases. And so you have to know the differences. And the PCO2 is slightly higher. That makes sense because the tissues are making carbon dioxide, and the carbon dioxide first has to get to the lungs before it's excreted. And then what you get on the arterial side is after the carbon dioxide has been excreted. There's this buildup in the steady state prior to coming to the lung on the venous side, and that's why it's 3 higher. That then drives the bicarbonate buffer reaction to generate more bicarbonate. If you remember that reaction on the first slide, when you increase the PCO2, just chemically, you're going to make more bicarbonate. And so that's why the bicarbonate increases a little bit. And if you do the numbers with the Henderson equation, the Henderson-Hasselbach equation, you'll get a slightly different pH. So you can see that the PCO2 tends to be in a male 43, and the bicarbonate is slightly higher, but essentially they're the same numbers, and therefore you can use these instead of drawing arterial blood, especially if you have a dynamic clinical situation where you want to know what the acid-base values are more than just, once every couple of days. You might have a sick patient where the acid-base values, or with your therapy, are changing more dynamically. You want to get repeated numbers. The other historic point, which we don't use anymore for many, many years already, is that people found out that the venous minus the arterial PCO2 has a functional correlation with the cardiac output. And as the cardiac output decreases, the venous PCO2 gets higher and higher and higher compared to the arterial. Now, people used to use this at the bedside before, and you can still use it. I mean, if you're really worried about someone's cardiac output and you can't possibly assess them more objectively with more modern technology, and you really want to be able to say to your attending, I'm really worried about the patient's cardiac output, this is a quick and dirty way of assessing it. Normally, you should get a difference of 3. But if you get a difference of 7, 8, 9, 10, 15, you have impaired cardiac output. And again, conceptually, it makes sense. You've got the tissues making carbon dioxide, and then you've got venous blood outside picking up that carbon dioxide. Well, if you think about it, the slower the flow of the venous blood per volume, there's going to be more carbon dioxide in that venous blood. As you slow down the flow, the concentration is going to increase. But when you get to the lungs, you blow it off again. This assumes that there's no problem with ventilation. So if you have just pure cardiac output decrease, but the ventilation is normal, you're going to see this difference. Once you impair the ventilation, then the PCO2 on the arterial side will also increase, and the difference decreases. So this is a patient with only cardiac output problem, but with normal ventilation, either spontaneous or on a ventilator. So just think of it. It's a nice little trick, especially if you have access to both bloods. And if the answer comes out 2 or 3 different, you don't have to worry about a cardiac output problem. So let's just look at each organ function. The PCO2, again, going to this equation, the PCO2 in the numerator is really representative of what the lungs are doing. And like all things in nephrology, it's really this is same sort of concepts. Nephrology really can be said in one sentence. It's a specialty where you're looking at the input and output of things and comparing them, no matter what that substance is. That really is nephrology. And so here we have the carbon dioxide that's created by the mitochondria in your body, and the lungs get rid of that produced carbon dioxide. And so in the steady state, then the concentration in units of millimeters of mercury is 40. I mean, it obviously would be a different number if we used kilopascals or other units. It doesn't matter. Historically, we use millimeters of mercury, and we're used to this number 40. But the concept is that we have a dynamic system like everything else in nephrology: sodium, water, potassium, magnesium, creatinine, BUN, no matter what it is. And the goal of nephrology is to learn the input-output systems for each of those and the diseases that affect the input versus the output. That really sums up nephrology. And the same thing is here. except it's easier because the production stays relatively constant. We don't have production problems with carbon dioxide other than if a patient has a fever. We used to use years ago a dialysis machine called the Ready machine, which you don't need to know about, but it created carbon dioxide. It was sorbent technology. And one of the problems with it was it actually was a source of carbon dioxide. And if the patient had issues with ventilation, you could actually create a respiratory acidosis, not because of lung problems, but because the machine was creating more carbon dioxide than the lungs could get rid of. In a sense, it was a lung problem still, but the initiation was a production of carbon dioxide. We don't tend to see this clinically. I mean, you can get more carbon dioxide created with fever, with thyrotoxicosis. You can stimulate the mitochondria under different clinical situations. But, you know, with normal brain and lungs, you just excrete that carbon dioxide and the PCO2 never changes. So it tends to be a problem with the excretion side, which is the lung. That's the organ that gets rid of carbon dioxide. So it's when the PCO2 goes up, you know a priori that the excretion capability of the lungs has decreased. Now you reach a new steady state when the concentration goes up enough. Now each breath gets rid of the same amount of carbon dioxide. So it doesn't keep going up forever. It plateaus. That concept keeps coming up in all of nephrology. And we'll talk about that when we talk about potassium and sodium and water and other things, that when you create a discrepancy between the production and excretion, you don't see that analyte go up forever or go down forever because the concentration changes, and then the change in that concentration allows the excretion of that substance to return to normal. It's a hard concept, but I'll show it graphically in later talks. So it's known in normal human that you make about 20 moles of carbon dioxide a day, and that's what you get rid of. It must be, without even making a measurement, if your PCO2 is staying the same. The bicarbonate is controlled by the kidneys. So the kidney has a problem because the concentration of bicarbonate in the blood is 25, and our GFR, let's say it's 120 milliliters a minute with 1,440 minutes in a day, that comes out to about 170 liters a day. Your glomeruli are filtering. Remember, you have about 1 million glomeruli in each kidney. And the total filtration of water is about 170 liters a day. I mean, you think about it, think about how many 2-liter Coke bottles that is. Now, we only have 3.5 liters of 3.5 liters of water in our blood. We have 5 liters of blood, but 6, that's not all fluid and not all the plasma, and only a part of the plasma is water. So, if you think about it, we have 2 to 3, let's say, liters of water in our blood. So we're turning over that water a lot to get the 170 liters. Obviously, we don't urinate 170 liters a day because we're absorbing in the nephron and about 169 liters back into our blood, assuming we drank a liter of water that day. If we drink 2 liters of water, we absorb 168 back into the blood and pee out 2 liters. But the issue for bicarbonate is every single liter has 25 millimoles of bicarbonate coming through all our glomeruli. So that's about 4.2 moles of bicarbonate coming through the glomeruli every day, which is about a box of Arm & Hammer baking soda. If you go to the cupboard tonight and look at a box of Arm & Hammer baking soda, that's how much bicarbonate comes through all your glomeruli. So the kidney has a problem. If nothing else happened after the glomeruli and you got rid of all that, in about 4 hours, your bicarbonate in your blood would be 0. So clearly something else is happening in the kidney, and in particular the nephron, that prevents that bicarbonate from ending up in your urine. So the kidney, because it filters bicarbonate freely, even without knowing anything, and knowing if you measure the bicarbonate in normal urine, there's no bicarbonate in normal urine. It's like very, very low. The fractional excretion of bicarbonate is like 0.2%. We absorb all of it. So knowing that there's no bicarbonate in the urine and knowing you're filtering about 4.2 moles a day tells you, without knowing any renal physiology, somewhere in the nephron, bicarbonate must be absorbed back into the blood. And it turns out it's the proximal tubule. We'll go into this briefly, and we'll talk about this more in later talks. But the first concept is bicarbonate gets across from the filtrate into the cell, and it does so indirectly via a protein called NHE3, which is what we call a sodium hydrogen exchanger. There's 8 of these in the mammalian genome, and this particular one is in all mammalian proximal tubules on the apical membrane. There's another mechanism for secreting protons, and this is called a vacuolar proton pump. It's made up of many, many proteins. We'll talk about that at a later time. It's shown here as a very simplistic little circle, but it's actually a very complicated structure. So via these 2 processes, protons are secreted into the lumen, and they combine with the bicarbonate that came through the filter to form, if you remember the initial bicarbonate buffer equation, form water and carbon dioxide. Okay, well, we still don't have bicarbonate in the cell. What happens is the water and the carbon dioxide get back into the cell. It turns out people now think via this protein called aquaporin-1. In fact, this was a reason for the Nobel Prize years ago. Actually, it was aquaporin-0, but there's many, many aquaporins, and they're water channels. But carbon dioxide and a number of different gases can actually go through the aquaporin water channel. And this is how these 2 substances get back into the cell. And then the reverse reaction occurs where we form carbonic acid and then the protons here, 2 protons, and ultimately carbonate. Both of these reactions are catalyzed by carbonic anhydrase. Carbonic anhydrase 4 is a membrane-bound carbonic anhydrase. There's many, many different carbonic anhydrases. It's a whole family of proteins. The carbonic anhydrase 2 shown here is a water-soluble cytoplasmic carbonic anhydrase. And they don't create the reaction, they just accelerate it. So both reactions, this one and this one, occur at a greater speed. But ultimately now what we've done is we've taken the carbon from bicarbonate and brought it into the cell in the form of carbonate. And then the carbonate leaves on another protein called NBCE1A. Our laboratory has worked on this for many years. It'll be part of another talk, but this protein transports 1 sodium and 1 carbonate from the cell to the blood. It does so to a large extent via a membrane potential, which is on this membrane. If you think about it, the sodium gradient is to enter the cell and the carbonate gradient is to enter the cell. The sodium in the cell is 20, outside is 140. And there's also a carbonate gradient. The carbonate in blood is greater than the carbonate in the cell, and yet this thing transports out. So the chemical gradients are the wrong way. They would drive these things into the cell. But there's an electrical gradient on the basolateral membrane of this cell and all cells in your body. And it's the voltage here that drives this, because as you can see, there's a charge here transported. Carbonate is 2 minus and the sodium is 1 minus. So there's 1 minus, there's a negative charge here that's carried every transport cycle. And this negative to positive membrane potential here is the driving force to drive this out of the cell. And there's different forms of proximal RTA that affect the membrane potential here, and also the affinity of this thing for carbonate that prevent its function. And we'll talk about that at a later time. The potassium channel here that's also on the basolateral membrane with the sodium pump are what creates this membrane potential. So they're essential for absorbing bicarbonate from the lumen to the blood, just because this side is electrogenic. And if it's confusing to you, don't worry about it. I just wanted to give you an overview of this complex process by which all mammals have evolved to take bicarbonate from the glomerular filtrate to the blood side. Now, we're taking actually carbonate, but the carbonate is in equilibrium with bicarbonate in the blood. So that's one thing that has to occur. The kidney must absorb the bicarbonate, but the kidney is faced with another problem, and that is, on an average North American diet, your diet makes acid, and it's made by the liver. And roughly 50 milliequivalents a day of acid are made in the form of hydrochloric and sulfuric acid, and they're pumped into the blood. And what happens is the proton from the acid, whether it's hydrochloric or sulfuric acid, combines with bicarbonate to make carbon dioxide and water. You get rid of the carbon dioxide, so you're fine as far as that, but now you've got a metabolic acidosis. It's no different than starting a hydrochloric acid drip on somebody. This is occurring in our bodies every day. And yet our bicarbonate is staying at 25. So this has nothing to do with reclamation of bicarbonate. It's a separate process that the human body and all mammals must deal with. So if this was allowed to occur and nothing else happened, your bicarbonate would be 0 in about 2 weeks. If you do the math, magnitude of the proton load, the volume of distribution, we won't get into that today. The acid load is not a fixed number. It depends what you eat. And people over the years have categorized food into whether they make acids or bases. If you eat, these substances on the right, you're actually going to tend to generate bicarbonate. You don't have to worry about this. You just pee out the extra bicarbonate. But if you eat processed cheese, egg yolk, meat, poultry, and fish, soft cheeses, these kind of things, those are very acid producing. And it comes down to what amino acids net are in the food. So glutamate and aspartate are prevalent here, okay, on the base side, and cysteine and methionine containing amino acids are on this side. And so it really depends on the amino acid. So lysine, arginine, cysteine, methionine make acid. Glutamate and aspartate are converted to net bicarbonate. And these substances, if you break them down into their amino acid components, have different net charges and different compositions of the amino acids. So people have come up with a scale. And if you want to start not producing acid and producing base, start eating these kind of things on the right. And in fact, people have talked about that in many, many articles, how humans over the years have changed their intake. And on a typical North American diet, we tend to have a proton load. And if you can't get rid of the protons or generate sufficient new bicarbonate, you tend to eat up your bones. There's all sorts of articles on the significance of a diet that produces net protons. So just to think about this schematically, on a typical North American diet, your liver is making this proton load. Again, the anion is chloride or sulfate, hydrochloric or sulfuric acid. But our bicarbonate stays at 25. So the way this works is the kidney actually is a bicarbonate generator. It generates the amount of bicarbonate needed to match the daily hepatic proton load. And that then creates carbon dioxide, which your lungs get rid of, but your blood bicarbonate stays at 25. So I think I'll end there just because of the time, and Ruth will set up the next talk, and we'll review what I talked about and continue. But the concept is that the kidney has two things that it does. It has to reclaim the filtered load of bicarbonate, and it has to generate an equivalent amount of bicarbonate to match the daily hepatic proton load. In the next talk, we'll continue with how the kidney generates this bicarbonate. This is separate from the bicarbonate that it reclaims. And we'll talk about the significance of ammonia production, which has a significance regarding the net amount of new bicarbonate the kidney can make. And then we'll go into, if there are no further questions, we'll go into the concepts of clinical acid-base chemistry and what are the rules and the approaches we need to take to approach real-world patients who have abnormalities in these numbers. But the important sort of take-home message with this is to understand what the normal kidney is doing and what the lungs are doing, because it really helps you understand the abnormality that you'll see in the clinical world if you first have an intuitive feeling for how the normal kidney is keeping the bicarbonate at 25 and how the normal lungs are keeping the PCO2 at 40, and also the interrelationship chemically in the Henderson equation as to how you can look at these numbers. And finally, from now on in your fellowship, not to call the results you get from the blood chemistries CO2 or bicarbonate. It should be called the total CO2. So I think I'll stop there.